Hello, everybody. Welcome to my MASLD MASH Community Network podcast. My name is Melissa Franco. I'm a PA at the University of Miami, and I've been doing hepatology for quite some years. So today I will be talking about discordant NITs and the gray zone. One of the points that I want to discuss will be giving you an example of a clinical scenario where we have discordant NITs about fibrosis staging, creating a discordant picture. So an example of this could be a patient that comes to your clinic for evaluation of MASH or MASLD referred by PCP or endocrinology, and you calculate a FIB4 that it's normal. You have abdominal imaging. Most common one is an ultrasound that shows a smooth liver without nodularity, no splenomegaly, portal vein is normal, no dilation, and you have a FibroScan that has a really high number, high liver stiffness number concerning for cirrhosis or advanced fibrosis. So this is a very, very common scenario that we get. And when this happens, what I do, I would repeat a FibroScan again, or I could also order an ELF score, which is a blood test that will tell me if the risk of cirrhosis progression in these patients. And then if you have availability or you're able to order an MR elastography, you could also do that to help stage your patient. So let's also discuss about what potential reasons there are that could give you these abnormal, these high numbers and this discordant non-invasive test. So let's start by FibroScan. So as you know, FibroScan evaluates how much fat, fibrosis you have, and then patients, before they do this FibroScan, they need to be fasting at least 3 hours prior to procedure. If patients are not fasting, this will give you a high number, okay? Also, if patient is obese, you need to change the probe for the FibroScan to give you a better number. Another reason could be operator variability. If you have an inexperienced operator, or maybe patients that are obese and you have a very narrow intercostal space, then sometimes it will give you a high number. Also think about possible other causes of elevation of liver stiffness. Could be hepatitis if you have liver enzymes over 100, AST, ALT, if you have cholestasis, if there is hepatic congestion, maybe patients have heart disease and there is hepatic congestion, then that could also give you a very high number. Or if there is a lesion or a mass in the liver, sometimes that could also give a very high number. Now think about FIB4. So FIB4, it's a calculation that we do. You could do it on the computer, you can do it on your cell phone, and then it requires the patient's age, AST, ALT, and platelet count. So keep in mind that FIB4, if patients are over 65 or if they are younger than 35, you should use a cutoff of 2 to worry about more fibrosis, okay? And any reason, any cause of elevation of liver enzymes or low platelet counts could also elevate this FIB4. For example, if you have a patient that drinks alcohol, maybe it's not telling you that how much alcohol they drink. Alcohol use could elevate AST and ALT due to hepatocellular injury, and alcohol will have a direct effect on bone marrow suppression and sometimes could lower platelet count. So if you have a patient that drinks alcohol and it's affecting the platelet count and elevating the liver enzymes, you're going to have a high FIB4, you can have an abnormal FIB4. Also think about other causes for low platelet count. Some hematological conditions, such as ITP or immune thrombocytopenic purpura, could give you low platelet count and will affect your FIB4. Also think about patients' comorbidities and medications that patients are taking. For example, if patients take immunosuppression medications such as azathioprine or Cellcept, Prograf, cyclosporine, methotrexate, sometimes these medications could have an effect on the platelet count and they will lower. This could lower platelet number. Now, the other point that I wanted to discuss was how I approach discordant NITs and what factors influence my decision to monitor, repeat testing, or pursue more advanced imaging. So I think that it depends on your patient. I think that you have to individualize these because every patient is different. You have to know your patient. You have to know their medical history. You have to know their comorbidities. You have to know what medications they take or they took before. Also, lifestyle. Does this patient exercise? Do they drink alcohol? Do they smoke? Do they have diabetes? Have they had diabetes for a long time? Or have they been on long-term medications such as methotrexate, amiodarone, tamoxifen, prednisone? So think about all these factors and look at imaging studies. Look at the ultrasound if you have anything available. We may need to order, well, after you do fibroscan, if your place, or if you have availability to order an MR elastography, you could do that. But sometimes these tests are not approved by the insurance. Sometimes I have patients that insurance doesn't approve fibroscan and doesn't approve ultrasound with elastography. So I'm left with FIB for ultrasound, or they're not going to approve MR elastography. So sometimes in these patients, I order a CT with contrast or MRI to look for signs of portal hypertension, to check for splenomegaly, to check for presence of gastric varices, esophageal varices that sometimes will show on imaging. And the other point that I also wanted to discuss was, how do I discuss discordant NITs with patients when these are inconclusive? So first of all, I explain to the patient what these tests are, how they're calculated, how we calculate a FIB4, how we do a good fibroscan, what this else signifies, how we do an MR elastography, while we do a liver biopsy. But when we have discordant results, and I explain to the patient that we have to get to the bottom of the issue that is staging their liver disease, because if we don't stage the liver disease, we cannot give appropriate management and appropriate follow-up for these patients, right? We have to know where they are. Also, if you're suspecting something else, an underlying liver disease, maybe an underlying autoimmune disorder like PBC or autoimmune hepatitis that is causing this liver enzyme elevation, or if you're thinking about maybe a drug-induced liver injury that is causing this liver enzyme elevation. So sometimes when you have these possible coexisting issues, underlying liver issues, or if you're suspecting iron overload, then I do biopsies. I order biopsies. So I try not to order biopsies because, as we know, this is invasive. And of course, an invasive procedure has its risk, bleeding, pain, but it usually happens at a very low rate. And sometimes we need biopsies because this is the gold standard method when we have to stage and evaluate for inflammation and fibrosis. And sometimes it's required for definitive staging. So thank you so much for joining. If you have any questions, you could always reach out to me. I'll be happy to help in any way I can. Thank you so much.